All righty. Good evening, everybody, and welcome to our webinar this evening. Thank you so much for joining us. Thanks for spending your evening with us. We have a really exciting topic to discuss tonight. My name is Mary Smith. I'm a physical therapist with Onondaga Physical Therapy, and we have teamed up with Syracuse Hearing Solutions to talk about all things vestibular, evaluations, assessments, and rehabilitation with a focus on an interdisciplinary approach. Couple logistics for tonight. We're going to do the entire presentation. Going to be just shy of about an hour, and we're going to do a question and answer session at the end. So either save your questions for the end, or you can put them in the chat bar at the bottom, and I'll record the questions and we'll have them all ready for everybody at the end. A little bit of an agenda tonight, or the objectives. We are going to talk about why and when to send your patients to a specialist, being an audiologist or a physical therapist, and the role that they play in diagnosing and treating vestibular disorders. They're going to go through a couple case studies and how a PT and an audiologist work together to diagnose and treat these mutual patients. We're going to go through assessments and testing processes, and then the treatments of the 5 most common vestibular disorders. I'm going to introduce, I'm pretty excited to do this part, introduce our panel of experts that we have here tonight. We have Dr. Nicole Anzalone, audiologist and owner of Syracuse Hearing Solutions, with offices in Camillus and in Fayetteville, which is where we're coming to you live from tonight. She holds a doctorate degree in audiology and a master's degree in neuroscience from both Syracuse University. Her and her team specialize in diagnostic hearing and balance evaluations, hearing aids, tinnitus evaluations and management, custom hearing protection, and auditory processing disorders and evaluations. In her free time, she is a drummer in her band, which I'm excited to hear. Another member of our expert panel is Deanna Derenbacher, physical therapist at Onondaga Physical Therapy. Deanna graduated from Damon University in 2020 with her doctorate degree in physical therapy. She decided to return back here to her hometown and has worked with Onondaga PT and is currently the team lead in our DeWitt location. She is also our education and mentorship coordinator for our entire PT clinical staff. Deanna, within her first 2 years, found that there was a large need for vestibular rehabilitation in the Syracuse area, and she got her certification through the American Institute of Balance, receiving her vestibular rehabilitation and concussion certification, as well as her vestibular rehabilitation 2 certification. Deanna treats a variety of disorders within the area of orthopedics, neurology, cardiopulmonology, and vestibular diagnoses. In her free time, Deanna likes to hang out with her husband, her 2 cats, and loves reading. So what I'm going to do now, I'm going to hop off the screen and I'm going to turn it over to our experts.
Okay, so my name is Nicole Anzalone. I'm an audiologist and owner of Syracuse Hearing Solutions. Today, we're going to talk about patients with equilibrium disorders. We know that dizziness is the #1 complaint to physicians by patients ages 65 and older, and the 3rd most common complaint amongst adults, only preceded by headaches and backaches. It's important to focus on the evaluation and management of these patients that have equilibrium dysfunction or dizziness related to their vestibular disorders, and be aware that these candidates and these patients may not be candidates for pharmaceutical or surgical intervention. So this requires a team approach for patient care for these patients and management and rehabilitation specialists. So why is this important? Falls are the leading cause of injury amongst the elderly, especially. This can lead to millions of emergency department visits per year. A lot of these patients may be in long-term care and need long-term rehabilitation, which can impact their life. They'll have increased risk of falling in the future. fear of falling, in which case they may start to avoid certain activities and may be sedentary at home. And a sedentary life leads to depression, isolation, and impacts them in other ways with depression. This hospitalization due to number of falls is also very expensive for the patient and even costs Medicare $32 billion annually. So not only does it impact the patient's quality of life, but is also a very expensive problem. It can also lead to mortality and fatality. So balance is a very complex and sophisticated system involving multiple sensory systems, including our vision, somatosensory perception, and of course, our vestibular system that starts in our inner ear. So because it's such an involved and complex system that affects our balance and controls our balance, this is another reason why it takes a team to be able to manage and care for these patients. Now, what is an audiologist's role in all this? Basically, our balance starts with our ears. Audiologists test and treat hearing imbalance disorders related to the ear. So our vestibular systems are basically our gravity centers. It gives us information about direction of gravity, as well as acceleration and deceleration of head movements. It is the gyroscopes of our body and arguably maybe the sixth sense. So as an audiologist, we provide neurodiagnostic vestibular balance evaluations, and our goal is to help these patients with their complaints of chronic and debilitating dizziness, vertigo, loss of balance, who are at elevated risk of falling. We focus on comprehensive diagnostic tests, not only of hearing testing, but also vestibular and cognitive function. So our job with all our comprehensive evaluations is to be able to better differentiate whether or not the vestibular problem is in the periphery, in the end organ, in the ear, or is it more cortical or involving the central nervous system. So if we know and can localize where the problem is occurring, we can allow for proper triage, first assessment, treatments, and outcomes for these patients. We want to be able to help physicians and other professionals, such as PT, make more informed decisions for their patients and be involved in those effective treatments for those patients. So as an audiologist, we also know there's so many studies out now about the increased risk of falling with degrees of hearing loss. And we know that a person is more at risk for falling 3 times more likely to fall with even a mild hearing loss, and that risk increases with increasing severity of hearing loss. And we know there is a relationship between hearing loss and falls, such as indirect pathways. These patients undergo changes in spatial awareness, increased listening effort, sensory deprivation to their system, and they undergo vestibulopathy. So the direct pathways also include, the aging ear, inflammatory processes, and changes in their vascular systems. And this tells us about the relationship between hearing loss and falls. So as part of our test battery, as audiologists in my office, we do extensive testing, not only of the auditory system, looking at hearing, auditory processing, tinnitus evaluations. We also look at cognitive function. We have a screening tool called the CogniView that looks at memory recall, reaction time, visuospatial sense in relationship to increased falling. We also do hearing aid treatment and tinnitus management for those patients. Today, we're going to focus mostly on our vestibular function test battery, which involves all these tests here that I'll talk about in more detail. So the purpose of all these tests is to be able to more specifically localize the site of vestibular function that are causing vertiginous symptoms. With our tests, we might be able to provide differential diagnosis of numerous vestibular disorders. We know that inner ear disturbances account for 80% of cases of vertigo. The other 20% are central. The most common peripheral cause of vertigo is BPPV, Meniere's disease, vestibular neuronitis, labyrinthitis, vestibular schwannomas, semicircular canal dehiscence, and so on and so forth. The most common central cause of vestibular disorder, which is getting a lot more attention now, is vestibular migraines. 30% of people who have migraines will experience vertigo at some point. And as well as we also look at these other disorders as part of the central vestibular system. So the purpose of this is to smooth the transition of patient care. We know that patients with hearing loss should be counseled about the effects of untreated hearing loss, tinnitus, and its relationship with postural stability and their increased risk of falling. And this is true of patients of any age. It takes a multidisciplinary approach to accurately diagnose and treat these patients because we are involved in non-medical management. And there is some overlap of treatment between audiologists and even PTs. So performing the tests that we do gives us critical diagnostic information regarding the physiological dysfunctions. And we can provide information for medical management, for even for vestibular rehabilitation. Most of these causes of vertigo cannot require medical intervention. They're best treated by vestibular rehabilitation in some cases. And we know that insurance may not allow for many visits for VRT. So by knowing and localizing the pathway of the problem, we can give more specific information and accurate diagnoses. And then PTs can offer more targeted and efficient therapies to allow for quicker and better outcomes for the patient.
Hello, I'm Deanna Derenbacher, and I am your vestibular specialist at Onondaga Physical Therapy. Now, if our patients have not had this advanced vestibular testing completed by audiology, I will also assess for central nervous system, peripheral nervous system, and even mechanical inner ear disorders in order to help deem if this patient is appropriate for PT or if they require referral to another provider, such as audiology, neurology, or ENT, for example. Now, with physical therapy, our goal is to help diagnose a variety of different dizzy disorders and to get this patient started right away on a treatment track. Some common disorders that we treat are going to include Meniere's disease. Now, with Meniere's disease, it's vital that we see these patients during an active episode. We'll go dive further into Meniere's disease, but even though these patients are not feeling well, this is when rehab is going to be the most effective for them when they are in these episodes. We also treat 3PD, or persistent postural perceptual dizziness, unilateral and bilateral vestibular dysfunctions or hypofunctions, Malday-Debarkment syndrome, psychogenic dizziness. We'll even treat vestibular migraines and cervicogenic dizziness. We'll talk more later about vertigo and the different canal involvements. And we also assess just general balance and gait deviations. We may see these patients after a cerebellar insult, if they have Parkinson's disease, MS, or even if they suffered a stroke, and we're going to be able to help give them a comprehensive balance evaluation while also looking into assisted device use as well. So our goal is to not only identify the functional impairments that these patients present with, but we also want to look into their functional limitations. This is where we directly partner up with the patient to establish goals that are going to be salient and meaningful to them. And then we work towards completing these functional activities, hopefully without symptoms and without limitations. Now, sometimes it may not be realistic to ultimately eliminate their symptoms, but we can utilize different strategies to help compensate if necessary. And we might see this in different central nervous system disorders or even patients with peripheral neuropathy. So with physical therapy, we're able to provide them different coping strategies. We can even teach them diaphragmatic breathing, different grounding strategies, such as possibly wearing very light ankle weights underneath their pant legs. And this helps to give them a little more input down into the surface. And then we also work a lot with different assistive devices. Now, I have a lot of patients that come in and they refuse to use a walker or a cane. They feel like it makes them feel disabled and uncomfortable, and they don't want to be seen out in the public with that. And I'm able to work with them to maybe find an assistive device that they'll use and they aren't fearful of. So this may include like a walking stick. And I explain to them, just because you have this walking stick doesn't mean it's for balance. It could also be to help improve your confidence, to help reduce your stress and your anxiety out and about. And I tell them, think of it as an extra leg. It's going to give you a little more input. Now, in the case of vertigo, it's vital that we see these patients as soon as possible because this can be a pretty easy treatment. The patient has minimal comorbidities, and if they have no other vestibular dysfunctions, these patients can be treated in approximately, on average, 2.5 visits. Now, we'll dive into vertigo a little bit further, but I've had patients that have suffered for months, even years, and we treated them within about 2.5 to 3 visits, and their quality of life improved drastically. So PT not only plays a big role in educating the patient as well about their symptoms, but we also get them back to what they love to do and improving their quality of life. So next, we're going to go through a case study that is actually it's a multidisciplinary approach. Syracuse Hearing Solutions and Onondaga PT, we both partnered together on this patient, and we're excited to show you our findings and how we work together to help this patient out. So in our case here, this is a 72-year-old man, and he has a pretty significant past medical history. He originally reported dizziness starting in 2017. And then he suffered a motorcycle accident approximately 40 years ago. From there, he was diagnosed formally with vertigo in 2018. Following that, he also suffered a brain fistula in 2018, and then continued dizziness post-brain hemorrhage in 2018. The patient was also diagnosed in 2021 with moderately to severe sensorineural hearing loss bilaterally. Other comorbidities include diabetes, arthritis, his history of a CVA, and then also his high blood pressure. Now, the patient came into both of our offices complaining of dizziness, general imbalance and instability with gait, hearing loss and also tinnitus, and then an uncontrolled right beating nystagmus, which we'll dive into a bit further in these next slides.
So when we first saw this patient, he did have a previous test report from another practice. Back in 2018, that's when he initially started to mention a different type of dizziness that he was experiencing. And so at that time, and the results of some of his report on shown on top here, he presented with BPPV. All his other tests look fairly normal. And this is just one of them, one of his smooth pursuit tests. And that was a few months before he had his cerebellar hemorrhage. And we saw him at the beginning of this year, and he had another vestibular evaluation at our office that showed a lot of abnormalities that would point to cerebellar dysfunction. One of the tests, for example, here was he presented with abnormal right beating nystagmus on smooth pursuit, as you could see in the circled area there. He had several other abnormalities on his test that pointed to cerebellar disorders.
In physical therapy, the patient was taken through further testing in which he presented with a spontaneous nystagmus and an abnormal gaze holding. He also had saccadic pursuits and positive convergence and divergence. With cerebellar testing, he presented with an abnormal dysdiadochokinesia. And then he came back positive on the Dix-Hallpike as well on the roll test. However, he was negative on the left. Now, the interesting thing is that he did present with an increase in symptoms during the Dix-Hallpike and the roll test. However, his nystagmus remained a right beating nystagmus that was horizontal in nature. This following video here shows the patient in video goggles. So his vision is completely denied. It's black within the goggles there. And as you can see, this patient is presenting with that right beating, horizontal spontaneous nystagmus. Now, when I asked the patient to look to the right, his eyes, that nystagmus would actually increase. And this follows Alexander's law when you look towards the fast phase of your nystagmus. And when you look to the left, it would slowly reduce.
So as part of our findings, it's important in this case that, we refer to neurology for follow-up. He was also followed up with us for hearing aids to treat his hearing loss as well as his tinnitus, which he also suffered from.
And then from there, he was also sent to physical therapy. We went through the entire test battery, and I decided I wanted to treat this patient for both horizontal and posterior canal BPPV. The patient was taken through a couple of rounds of canalith repositioning maneuvers. However, we did not have a resolution in his symptoms, and he continued to present with his right beating nystagmus within the maneuvers themselves and post with spontaneous nystagmus, saccades, and smooth pursuits. The patient was, however, provided with different substitution strategies for his gait. We worked on trying to narrow his basis support to within normal limits, and we also discussed different grounding strategies. One that worked really, really well for him was actually having in place both of his hands on his hips. And I had him really press deeply into his sides, but also down into his basis support. And with walking, he did report improvements with his balance. The patient was also given different substitution strategies. And then I also had him further follow up with his neurologist as well, as a lot of his symptoms seem to be coming from that central nervous system, specifically the cerebellum.
So I would like to talk in more detail about the assessments, the comprehensive evaluation for vestibular testing that we perform and all their subtests. So basically, our tests look at the vestibular system starting from the end organ, 6 semicircular canals and 4 otolith organs, all the way up to the brainstem. And here's a list of the subtests that we perform. Again, there is some overlap between tests that we perform and tests that PT also performs. The sensory organization test is a test of postural stability. We also perform video nystagmography, which is the gold standard of vestibular testing, looking specifically at the VOR system. We also do bithermal calorics as well. We have a rotary chair, which is behind us here in my office, which is also a gold standard for testing. And it has many benefits as part of the test battery. We perform VEMPs, which are very specific to the otolith organs of the utricle and saccule. So those are the only tests that could test a function of those two. We do auditory brainstem response testing, rate studies to look at retrocochlear disorders and pathologies. Electrocochleography, which can tell us if a patient is suffering from Meniere's. It's a great way to diagnose that. And dynamic visual acuity test, which tells us about solopsia. So the first test we do, looking at the sensory integration and balance test, Basically, it's a combination of 4 different tests. It's a very quick and easy test, looking at postural stability. So it's a combination of Romberg, CAT-SIB, Fukuda step test, and the tandem Romberg test as well. We perform this with and without vision just to see if the patient is relying on their visual system, and that could tell us whether or not a patient may have either peripheral vestibular disorder or a neurological disorder. It could also tell us if the patient is at a fall risk. The next series of tests we do is called video nystagmography or VNG test. This also has various different subtests. Basically, we are looking at the vestibular ocular motor reflexes, and it could tell us whether or not, or we could localize whether or not the vestibular disorder is peripheral or central. Some of the subtests that it contains is gaze-evoked nystagmus, saccades and smooth pursuit, positional testing, and bithermal calorics. So in a lot of these tests, we could see if there's any weaknesses on one side or the other, asymmetries between ears, and also problems along the VOR vestibular pathways. Another test that we do is rotary chair. The benefit of rotary chair is similar to calorics, but it tells us about more frequencies involved in vestibular function. We're basically looking if the patient is able to suppress induced nystagmus. We're looking at phase and symmetry abnormalities. It could also tell us if the patient is having a compensated or uncompensated vestibular problem or dysfunction. So it is a little bit more sensitive to that than calorics. We're also looking at the measurement of the horizontal canal dysfunction specifically because they are moving in accelerating in a lateral plane in both directions. Dysfunctions of VOR, there've been some studies on this, looking at compensatory motion as in motion sickness and peripheral vestibular dysfunction. Some of the benefits are you can actually use this to test children, pediatrics who cannot tolerate caloric testing by having water or different temperatures of air in their ear. So it's pretty easy test to do and very quick. We also look at auditory brainstem responses, again, neurologic rate studies. Basically, this is sensitive to vestibular schwannomas, 1 centimeter or larger in size. We could look at demyelinating disorders or MS, as well as hearing loss and asymmetries in hearing loss. It's a great test to do in lieu of MRIs if the patient cannot undergo MRIs or if they're contraindicated for MRIs. This is a great substitute because it could tell us a lot of information. Basically, we're measuring waveforms along the auditory pathway from the inner ear all the way up to the inferior colliculus. And any asymmetries or delays in those waveforms can give us information about where the problem is occurring. Another part of our test battery is electrocochleography. This tells us about the fluid dynamics of the labyrinth of the cochlea. It's sensitive to detecting endolymphatic hydrops or Meniere's disease, vestibular migraines, perilymphatic fistulas, or autoimmune inner ear disease. It is more sensitive if the patient is active, inactive Meniere's, as patients with Meniere's disease usually undergo fluctuations in episodes. Also, they may have low frequency hearing loss, so we do hearing testing as well as presenting with oral fullness and tinnitus that may sound like roaring or whooshing. During this test, we are looking at the SP-AP ratio in between ears, because usually Meniere's disease more commonly is unilateral, can be bilateral as well. But if there's a large SP to AP ratio that could be abnormal, that indicates the patient is active for Meniere's. Another part of our test battery is vestibular evoked myogenic potentials, or CVEMPs and OVEMPs. I kind of combined them due to lack of time. These are the only tests that evaluates saccule and utricle and their dysfunction. OVEM specifically look at the VOR ascending pathway of the utricular function. We see the OVEMP montage here because it's actually measuring myogenic potentials from the eye muscles in response to stabilizing our gaze. So that's the purpose of the utricle and the superior vestibular nerve pathway. CVEMPs look at the descending motor pathway. And here we're actually looking at the responses from the sternocleidomastoid muscle, basically our neck muscles that stabilize our head in response to motion. And actually a fun fact is chickens have really great VCRs, vestibulocoelic reflexes. You can move a chicken and their head will remain perfectly still. It's pretty amazing to watch. You can see videos on YouTube. But anyway, this is a reflex pathway that we're looking at to see how the head responds to changes in senses and the otolithic stimulation. Here we could look at dysfunction related to like semicircular canal dehiscence. They'll typically have an enhanced waveform on one side. One of the best ways to actually test for it, it's a pretty sensitive test to it, in which case we would refer to, for medical management to an ENT. Any other sorts of dysfunction, we might also refer to a neuro as well, but it's pretty sensitive tests. Now we have to look at our test battery as a whole. These subtests in and of themselves may not tell us too much, which is why we have to look at all the tests as pieces of the puzzle. So our VEMPs may look different depending on what the pathology is. Typically in otologic pathologies, you might see like Meniere's disease. It might be enhanced while they're in active Meniere's episode. If they're more towards the burnout, they might actually have absent or reduced VEMPs. It's also good to know that these have age specific norms past a certain age. They're not easy to record, so we have to keep that in mind too. But also looking at other otological pathologies, superior canal dehiscence, like I was saying, you might see an enhanced response on the CVEMP. Neurolabyrinthitis or vestibular neuronitis, you might see absent or reduced responses, especially unilateral or asymmetrical responses between sides. Some neurological pathologies that might change VEMPs or be sensitive during VEMP testing is vertiginous migraines. A lot of these neurological responses are delayed. They'll show delayed waveforms. Sometimes in more severe cases, they may be also absent or reduced bilaterally in many cases.
Now, in regards to the PT test battery, if the patient has not had this testing done, I will conduct a series of tests and measures to decide, are we dealing with a central nervous system disorder, peripheral nervous system disorder? Is this a mechanical inner ear vertigo disorder? And are we also considering some oculomotor symptoms as well? So within my central nervous system testing, I'll look at smooth pursuits, gaze-evoked nystagmus and saccades, as well as near point convergence, VOR cancellation, and also spontaneous nystagmus. When looking at the peripheral nervous system, we'll further look into the VOR and also take into consideration their spontaneous nystagmus if present. We'll also look at dynamic visual acuity, the head shake test, and even the Fukuda step test, which is also a branch under that GANS SOP testing. If we think it's a mechanical inner ear disorder, this is where I'll look into posterior horizontal canal and possibly anterior canal involvement. and we'll dive further into these different maneuvers later. For my oculomotor test battery, I'll look at the cover test. And then in regards to balance, I utilize a whole combination of different functional tests. One of my favorites, and that gives me the most information, is the GANS SOP, but I'll also look at the Berg, the CAT-SIB, the DASH, or even the dynamic gait index. So now we're going to go through the top five vestibular disorders that we treat. We're going to start off by going through BPPV or vertigo. We'll then move on to vestibular hypofunctions, both unilateral and bilaterally. I'm going to take a look at MDDS or Malday-Debarkman syndrome. Then we're going to look at Meniere's disease and tinnitus. So with BPPV, we all know that the most hallmark sign and symptom is that room spinning dizziness with changes in positions. Now, vertigo can be a lot more than this. This is where a very thorough evaluation must be conducted because not all of your patients are going to report that symptom. I've had some patients describe it as, I feel like I'm in slow motion and I'm trying to catch up to my body. I've had other people say, I just feel unsteady and off balance, which we'll find is very common with a horizontal canal involvement. Other people will say, I feel lightheaded and foggy and I just can't think right. And then other people may describe it as more of like a tilting motion. Other patients sometimes will just have this vomiting and nausea with their episodes. And we see that 50% of individuals over the age of 70 years old will experience BPPV at some point in their life. So this is where if I have a patient coming in for gait or balance disturbances, not even just dizziness, I will take a look at vertigo testing because I've had a majority of my patients not even know they had vertigo when I tested them. And then immediately after we complete the canalith repositioning maneuvers, they actually notice a huge difference in their balance immediately. And then from there, we can further assess that balance impairment if one remains. Now with BPPV, we're going to find that the most common canal is that of the posterior canal. This is going to make up about 60 to 90% of all cases. From there, the next most common is going to be that horizontal canal vertigo, which is about 5 to 30%. And this is where a lot of your patients might describe it as more of imbalance with walking and just general falls. Anterior canal involvement is going to be extremely rare. This is less than 5% of your cases. And the typical presentation for an anterior canal involvement would be if someone dove headfirst into a pool and hit their head. It's not very common at all. And then typically, BPPV will be unilateral in nature, but depending if they have a mechanism of injury, such as a car accident or even a concussion, they can present with multi-canal involvement. And this is anywhere from 6.8 to about 20% of all cases. So with multi-canal involvement, this really requires a provider that knows what they're doing because there's a certain order that we need to treat these patients. We can't just treat all of the canals all at once. We have to have a very systematic progression in how we treat these patients. So what is the importance of going to a certified provider for vestibular therapy? Well, like I mentioned, we have to not only decide, is it the right side, is it the left side, is it multi-canal involvement, but you also have to have a provider that knows how to complete not only the testing positions, but also the canalith repositioning maneuvers. These maneuvers and testing positions require very, very specific head rotations and even extension. And if that patient were to sit up in the middle of one of those maneuvers, they could have actually what we call canal conversion, where that crystal now pops into another canal. And this is when symptoms can get a lot worse. So this is why I tell my patients I do not recommend going onto YouTube and finding a video and trying to complete these maneuvers themselves, because we have to first decide the correct side, and then we're going to dive into the pathophysiology. We have to make sure we're treating the correct type of vertigo as well. So in regards to BPPV, we actually have like two different subtypes. We have canalolithiasis and cupulolithiasis. So canalolithiasis is when the otoconia is actually moving within that semicircular canal. It's in that free-floating fluid. So when I take this patient down into a Dix-Hall pike, for example, where their head rotated and extended, for their nystagmus, I'm actually going to see a delay in the onset of their symptoms and their nystagmus. And that nystagmus is going to fatigue, typically within 30 seconds or less. Now, if I'm dealing with a cupulolithiasis, now that otoconia is actually attached to the gelatinous substance. So now that cupula is billowing back and forth from the weight of that crystal on the cupula. So when I take these patients back into the Dix-Hall pike, they're going to have an immediate onset of symptoms, and that nystagmus is not going to fatigue. It can last minutes. So it's vital that we're able to distinguish between the two of these, because only certain maneuvers are going to treat your cupulolithiasis. Other maneuvers, all maneuvers actually, will treat your canalolithiasis, but only certain ones, the cupulolithiasis. Because now with the cupulolithiasis, we have to get that crystal off the cupula, and then we have to get it around the semicircular canal. So it's kind of like a little extra step there that we have to keep in mind. We also have to make sure that the provider you send your patient to knows their nystagmus patterns as well. The different canal involvements will have different nystagmus patterns. In posterior canal, BPPV, these patients are going to present with an upbeat torsional nystagmus, and the top pole is going to be towards the dependent or the down ear when you're in that maneuver. With horizontal canal testing, they're going to have a strict horizontal beating nystagmus without that rotational component. Now, with horizontal canal treatment and testing, we have to keep in mind that those horizontal canals will work in functional pairs. So even if the right side is involved, when I take my patient through that roll test to the left, they may also present with a nystagmus. So this is where you have to have a really keen eye to be able to distinguish which side has the larger amplitude nystagmus, and then that will give you the side that you want to treat. And then in case you run into an anterior canal vertigo, these patients are going to present with a downbeat nystagmus. And sometimes they'll have a torsional component, sometimes you won't. So once we properly diagnose these patients using the Dix-Hall pike and the roll test, from here, we then have a whole test battery of different canalith repositioning maneuvers that we can utilize. So for posterior canal involvement, we can use the Epley or the Semont maneuver. Now, in this case, the Semont maneuver will treat your cupulolithiasis, where the Epley will not. I have also had some patients that cannot lay on their back. They will refuse to lay supine. They can't lay supine. So this is where it's going to be important that you have a great toolbox of different maneuvers to complete. So that way you can still treat these patients, but in a more comfortable way for them. From there, to treat horizontal canal vertigo, we can utilize the barbecue roll maneuver or the Gufani and Appiani maneuver. Now, I honestly do not utilize the barbecue roll maneuver. I just find that it is not realistic in my practice. We have these very small tables that the patients are on, and the majority of my patients are over 60 years old, and they're limited in their mobility and their ability to complete transfers. And for me to be able to keep them in very specific positions is tough. So that's where I like to utilize the Gufani and Appiani maneuvers. It actually has evidence that supports it's superior to the barbecue roll, but it's a lot less movement for the patient, and it's a lot less stressful for the patient as well. And then if you come across that anterior canal vertigo, this is where we can utilize the deep extension maneuver, or you can even utilize the Semont maneuver. And this is because for example, the left anterior canal is going to correlate with the right posterior canal. So that connection there allows us to utilize that Semont maneuver almost in reverse in order to treat that anterior canal vertigo. Now we're moving on to vestibular hypofunction. So first we're going to look at a unilateral vestibular hypofunction. And this is when you have partial or complete loss of function of the peripheral vestibular sensory organs or even the nerves. There's many different causes. It can be just your common cold or an earache. It can be due to vestibular neuritis, Meniere's disease, trauma, or even surgical intervention, different ototoxic medications, or even lesions of that vestibular cochlear nerve or the labyrinth itself. Now, these patients will often complain of oscillopsia and dizziness, nausea, and general imbalance with their gait. Now, looking at bilateral vestibular hypofunction or dysfunction, this is often found in our bilateral lateral semicircular canals or involvement of the superior vestibular nerve. Now, these patients, their chief complaints will be that of unsteadiness, and this will be most likely noted with vision denied and on uneven surfaces. And this is where that GANS SOP test is a great test for these patients, because not only do we have this thick red foam that the patient is standing on, we also work in vision, eyes open and eyes closed throughout the test. So for unilateral vestibular hypofunction and bilateral dysfunction, this requires a hybrid approach. So our goal is to integrate selective attention, memory capacity, and also processing speed activities into their vestibular rehab therapy in order to produce optimal outcomes. Now, there's three main overarching categories or strategies that we utilize in vestibular rehab therapy, and they include adaptation, habituation, and substitution. So with adaptation, our goal is to actually enhance the recovery of the VOR. So we're going to put these patients through repetitive activities that include different situations and even movements that provoke their symptoms. But the key here is that yes, we want to increase the symptoms, but we only want to increase it about 3 points from their baseline. If we overload these patients, their symptoms are just going to keep increasing and increasing, and they're going to have elevated symptoms for hours or even days even. So we want to actually get these cyclic changes in their symptoms, and this will help to induce that plasticity of that central nervous system. Now, looking at habituation, our goal here is to provide repetitive exposure to that provocative stimulus. And then over time, this will result in a reduction in that pathological response. So this is where it's key that we really interview this patient and understand where their functional limitations are, because speed, direction, and frequency are going to be key with these exercises. And then looking at substitution, this is where we want to present the patient with different dynamic and challenging surfaces with multi-plane stimulation. We really want to challenge their vision, and we also want to force that reduction of their surface dependency and stimulate those proprioceptors of the joints. And with balance therapy, it is also extremely important we add in a cognitive task whenever possible. Studies have been completed extensively on the addition of a cognitive task with different balance and even gait activities, and superior outcomes are found when we add in that cognitive component. It also better fits into the patient's activities of daily living and when they're out and about in the community. I can have a patient stand on a piece of foam for as long as I want to improve their balance. That's going to take a long time, and it's not going to transition out into the community in their daily life. Next, we're going to look at Mal-Day-Debarkment syndrome. Now, a common misconception I hear is that, oh, I wasn't on a boat, so I can't have it. But MDDS can occur even after car travel, a train ride, or even travel on an airplane. Now, the theory behind MDDS is that the central nervous system is actually unable to reset that sensory integration once that patient is on solid ground. So it's almost like the body craves that motion. So on that boat ride, we have that constant kind of swaying back and forth. Even though it's may just be a little bit, it still can kind of reset that nervous system. So now when that patient's on solid ground, they crave that motion and their body brings on these symptoms of dizziness and imbalance because it's not used to the solid surface again. So there's some really fun strategies that I'll utilize. One of them being sitting on an exercise ball and bouncing. So I'll set up a specific program for these patients, very specific intervals of time and numerous times throughout the day. And we slowly dwindle that with time. And this actually helps to reset their system once they're back on solid ground again. Now, MDDS is the most common in premenopausal females as well. So symptoms that these patients will report will include this persistent sensation of the swaying or rocking. Some patients may even say it kind of feels like they're drunk walking. They'll also have the increased symptoms when stationary, and their symptoms will improve with motion. And these symptoms can last hours or even days. So I discussed one of the strategies that I utilize, such as bouncing on the ball. But other than that, with physical therapy, we have to make sure we go through a very systematic progression. We have to start with dynamic surfaces and movements, and we then have to retrain the system that we're slowly going to eliminate those dynamic surfaces and progress to more static conditions to help reset that system. In other patients, I will also refer them out for cognitive behavioral therapy, and we'll also utilize different habituation and grounding strategies to help them get through their current episode. Next, we're going to take a look at Meniere's disease. Now, with Meniere's disease, this is when we have an alteration in either the production, the flow, or even the absorption or reabsorption of the inner ear fluid. So in this picture here, you can see this distended endolymph in that image below. Now, patients may have one episode every few years, weekly, or even daily. And post episodes, these patients may or may not have residual symptoms. Now, despite these patients not feeling very well during these episodes, it's really important that we try to see these patients during these active episodes, not only from a testing perspective, but also for a treatment perspective as well. Meniere's symptoms are going to include vertigo that can last anywhere from 1 to 24 hours. They may have fluctuating hearing loss, tinnitus, or even fullness in their head and their ears. They may also have nausea, vomiting, and diarrhea. Now, in regards to PT treatment, we will utilize those 3 strategies that we discussed previously: the adaptation, habituation, and substitution. And all of these exercises are individualized for each and every patient. There is no cookie cutter treatment for vestibular therapy. We have to make sure that the exercises we're doing correlates to their daily life and the activities they want to return to. Now, in the case of Meniere's disease, if the patient does not have symptoms in between their Meniere's episodes, vestibular rehab will be ineffective for this category of patients.
So some of these patients may present with tinnitus. So it's kind of a coexisting occurrence with otologic problems. So tinnitus is basically the perception of sound without any external acoustic stimulus. So it's due to, and a lot of studies are showing that it's occurring not in the ear, but further up in the brain. fMRI studies are showing activity in the dorsal cochlear nucleus, and it also involves a pathway up to the limbic system. So it's the same neurologic pathway that when we hear an alarm go off, it excites our fight or flight response. So it's important that we try to move away from telling these patients there's nothing we can do about it, because we can manage the tinnitus, we can hopefully reduce the tinnitus, and that is the goal for our patients. Some risk factors for tinnitus are hearing loss. 90% of the time, if someone has persistent or chronic tinnitus, there is some related hearing loss, in which case, as soon as someone mentions that they have the symptoms of tinnitus, we will do a hearing test. There are also cases of ototoxic medications that may cause it, head injuries, depression, and again, limbic system effects such as fatigue, stress, that can definitely exacerbate tinnitus. There are also cases of cervicogenic tinnitus, vascular tinnitus, which case patient may experience pulsatile tinnitus that syncs with their heartbeat, or when they turn their head or jaw, they might notice some changes in their tinnitus. So in these cases, taking a very thorough history with these patients is very important. There's also, of course, the risk factors of prolonged noise exposure after a loud concert, looking at some infections, even impacted earwax can sometimes cause tinnitus. So an otologic inspection is very important in these cases. And treatment of tinnitus is very important too. And we know there's no cure, but we definitely can help these patients. Some of the ways we can treat tinnitus, and some of the most successful ways, is starting simple with a masking or sound generator. Using sound therapy can help reduce tinnitus in about 60 to 70% of patients. It may not completely eliminate the tinnitus, but it can hopefully get to the patients to a point where they don't notice it as much. So we're basically using a sound to reduce the sound of their tinnitus, keeping the line busy. So we want to blend into the sound of their tinnitus to help reduce it the best. So sometimes we'll do some pitch matching of the tinnitus, or sound matching, sound blending techniques, and of course match the level of the tinnitus as well. So you're not introducing another annoying sound to replace the annoying tinnitus. If the patient has hearing loss, hearing aids are a great way to treat both hearing loss and provide tinnitus masking. They're separate programs that the patient can access using a button on their hearing aids to switch into a masker mode, or even using an app on their phone to adjust it to match or help blend into their tinnitus. And I would say it's pretty successful. I've had some patients who were really debilitated by their tinnitus, can't sleep at night, relied on medications to help them sleep. And we have gotten them to a point where they could tolerate it, where it sounds like the tinnitus is not internalized so much, but more so just part of room noise that they could try to ignore or forget about. That's also the purpose of tinnitus retraining therapy, which we also perform regularly with our patients. It involves intensive counseling as well as sound therapy for the habituation process of the tinnitus to augment the perception of that tinnitus. Again, we want them to not internalize it like it's always there in their head. We want it to become separate from them, isolated from them, and become maybe part of room noise or background that they could ignore. Other therapies is cognitive behavioral therapy. Now, this depends on the severity of the patient's tinnitus. We do extensive questionnaires to try to figure out where the patient stands and how severe the tinnitus is. I recommend cognitive behavioral therapy for those patients who are really debilitated by their tinnitus. They might mention that they have suicidal thoughts even because it is catastrophic to them. I typically refer out for this to a professional who specializes in cognitive behavioral therapy, a psychologist, a counselor, a therapist would be the best bet for these situations.
Now, if the tinnitus is due to cervicogenic reasons, for example, impingement of the suboccipital nerves, PT will be an effective treatment as well. So here we are able to use different soft tissue techniques and manual therapy and mobilizations. And then we also work a lot on postural re-education, as well as a lot of work on the deep neck flexor muscles themselves and the endurance of them as well.
So as we conclude our talk today, the basic goals that we have are trying to develop a cooperative relationship with the professionals in the community. These patients need very involved care by multiple professionals and multiple specialists. A lot of these patients rely on non-medical management for their care for their vertigo and even tinnitus, where they're not candidates for pharmacological or surgical care. We do want to involve the professionals in a symbiotic relationship so that we can make management and care for these patients much easier. I must say also that, even my daughter had vertigo. She had horizontal canal BPPV as triggered by probably a viral infection. And I referred my daughter over to Onondaga PT for care. Luckily, I had the very expensive and great equipment to be able to test her to kind of pinpoint what the problem was so I could get her the best care she could get. So that's another case, a very personal case of how we work together to help manage these patients. So, and the goal and the purpose is we want to be able to make this effective treatment as simple for the patient as possible. We want to reduce overall patient visits. Where do they need to go? Sometimes they don't know that. Do they need an electrician or a plumber? I always joke around and say that, but sometimes they just don't know where to go and they rely on their physicians to help direct them to the right specialists. We want to be able to reduce patient and insurance costs, reducing the falls, reducing hospital care, and that long-term care management. We want to be able to diagnose a patient quickly so they're not suffering for long periods of time. And this allows for more direct treatment. We want to improve their patient care overall and their medical management and work with the physicians, their physicians to find the best care for them as possible. And this, overall improves their quality of life, and it makes a less confusing experience for them. Within the medical system, a lot of times they don't know where to go and they're sent here and there. And sometimes it could be something simple. We could find a simple way and a quick way to treat them, even within 1 or 2 visits for therapy, even, and that's all they may need. So by doing this, we're improving their treatment efficacy and giving them better patient outcomes.
Now, on the following slide here, we have some great resources for you to take a look at and to dive further into the literature. So these are some great examples that I have utilized in my research as well. And next up, now we have our Q&A. We appreciate your attention and for listening.
Thank you.
All righty. Thank you both so very much. We do have one question in the chat panel. I'm going to read off to you both. It's from Gary Spink. You had mentioned cognitive testing via the cognitive system can be part of an assessment. What type of cognitive difficulties or profiles would you be looking for? Also, how would that information be incorporated in the evaluation?
So we have a system called the CogniView test. It's a screening test. Basically, we started doing that test to help with the patient cognitive care. We know there's a relationship between hearing loss and early cognitive decline, as many research studies are showing, and how even a treatment with hearing aids can help reduce that early cognitive decline by 48%. There was a huge study by Achieve, a multi-facility study, and that's why we incorporated it. The test shows 5 different parameters, reaction time, processing speed, visual spatial sense, general memory, and executive function for problem solving. This test is becoming more and more popular because it's very regulated. There's no examiner bias involved. They don't have to write anything. They don't have to really listen. They just follow, follow the test. It's like a little computer video screen. And basically, in correlation with number of falls, Dr. Richard Gans from the American Institute of Balance is currently doing studies and showing that even decreased reaction time and processing speed on these tests, on the test results, can be related to increased risk of falling. So if a person can't react fast enough, as you can imagine, they're more likely to fall. And his studies are showing that people are 14 times more likely to fall if they score low on these tests. We also use these tests to try to figure out how we could better manage the patient who has hearing loss. If they have poor visual spatial sense, we have to spend extra time with them, extra time giving them directions, getting their families involved, and getting the physicians involved for further memory and cognition testing. I hope that answered your question.
All right. Thank you very much. Yes. If anybody at this point has questions, certainly feel free to unmute yourself and just toss the question out to Nicole and Deanna. While we're waiting for some questions to come in, I just want to remind everybody that this is being recorded. So you will receive a copy probably tomorrow in your email. If you should come up with any other questions at that point that you want to ask Nicole or Deanna, you can simply reply to that email, or you can email marketing@onondagapt.com. And we can get that question to Nicole and to Deanna so that if anything comes up over the next few hours or as soon as you sign off, we can certainly help get that answer. Let's see, it looks like we've got, okay. Couple other things to just review. We do have wanted to talk a little bit about locations. Nicole Anzalone and Syracuse Hearing Solutions are here in Fayetteville and in Camillus. And Onondaga Physical Therapy has 8 locations around Syracuse. We are in Fayetteville, DeWitt, Camillus. We are in Cicero, Liverpool, Baldwinsville, 2 locations in Clay, and 1 in Wolcott. The information, contact information is also going to be in the emails. So if you have any questions as things come along, or if you're watching it, we also encourage you to please share with fellow healthcare providers or anybody that may be looking to help care for people with vestibular symptoms or diagnoses. Does anyone else? I don't see any more questions in the chat bar, but wondering if there's any other questions. Making sure I didn't miss one. Sorry, everybody. All righty. So there will be a post seminar a survey that's going to pop up when you sign off. We would really, really appreciate some feedback on how we did tonight. And if there's any topics that you would love to hear us discuss, please feel free to respond with that as well. But I think we may close out. Sorry, just double checking. It looked like there was one more question. Didn't want to skip it. Looks like we will be closing out for tonight. Thank you all again for attending, and have a wonderful night.